All right. The primary assessment, as you'll see, the whole purpose of the primary assessment is to focus on life threats. We use the letters ABC. Some will even throw in a D for disability, but ABC is what we're assessing during the primary assessment to see if there are any life threats. Obviously, an obstructed airway would be a life threat. Inadequate breathing would be a life threat. Hemorrhaging or low blood pressure or no circulation or no pulse certainly would be a life threat. So during the primary assessment, um, we're looking for those life threats. And when we find a life threat, then we need to fix it before we move on to any further assessment. The order of the ABC depends on the initial impression of the patient. And what they mean by that is that the sequence may vary. The American Heart Association teaches us that, if a person is unresponsive and has no pulse, then we start with circulation first, chest compressions, and then airway and breathing after 30 chest compressions. Where normally we're going to look at the airway first, assess their breathing, and then check their pulse and look for serious bleeding. In another situation, you may have a patient who has significant life-threatening hemorrhage and arterial bleed. You arrive on scene and you see blood squirting out of their wound every time their heart beats. Your focus is going to be on C first, controlling that hemorrhage with perhaps a tourniquet, and then move on to A and B. So immediate interventions may be needed, like opening the airway, assisting ventilations, or controlling hemorrhage or doing chest compressions. Note that any vomit that's in the airway can also get into the lungs. That's called an aspiration. If a person aspirates vomit into their lungs or sucks that vomit down into their lungs because they're unable to control their airway, that little bit of vomit, even a teaspoon, could cause a pneumonitis or an inflammation, a pneumonia-like infection in the lungs that could be fatal. Exsanguinating bleeding has to be stopped immediately with a tourniquet, and then breathing and circulation are absolutely vital for life. In fact, the two most immediate threats to life are not breathing and hemorrhaging. So if immediate interventions like bleeding control or CPR are not required, then you can shift into an important but less urgent mode, which will allow you to do things like administer oxygen if it's appropriate, and evaluate for the presence of shock. Also in the primary assessment, once we've looked at our ABC, we will form a general impression. And the general impression is simply answering the question, sick, not sick. As we look at the patient, do they look sick? Are their eyes all glassed over? Are they not alert? Are they pale, sweaty, or gray? Are they cyanotic? Just by looking at them, you can form a general impression of the sick, not sick. And initially assessing their mental status would be AVPU, and then assessing their airway for patency, their breathing for adequate rate and depth, and their circulation for strength and rate of the pulse, as well as the presence of hemorrhage. And then based on what you find in your primary assessment, you can determine the patient's priority. Are they a high priority patient? And we'll discuss what makes a patient high priority. In forming a general impression, you also want to look at the environment as well as the patient's chief complaint. I had mentioned their appearance, but also finding out what's wrong with the patient or what the patient is complaining of, as well as the environment that they're in. This too will help determine the patient's severity, and it'll help set your priorities for care and transport. Some people talk about the look test, and that's a feeling that you get from environmental observations as well as your first look at the patient. Some would include the door test. As you walk through the door, if you can hear audible sounds of wheezing or audible sounds of stridor, then you know the patient has a significant breathing problem. So forming a general impression includes just your immediate assessment of not only the environment and the patient's chief complaint, but how do they look? Looking at this particular girl in the picture, She's obviously sick. She is bleeding, and even a small amount of blood on a white rag can look significant. But she's also got the abrasion above her head. Her eyes are open and she is awake. So, her immediate threat, if any, would be the bleeding that we see. But don't get tunnel vision. Without actually seeing her in person, we don't know what her lung sounds like. We're not able to see her respiratory rate and effort. We're just able to see that bloody rag. You want to identify patients when you form your general impression who may be critical. Patients obviously who appear lifeless, we need to begin CPR and hook up an AED as soon as available. A patient who has an obvious altered mental status is a high priority or critical patient. A patient who appears unusually anxious or pale or sweaty, which could be early signs of shock, would be considered a critical patient. Patients who have obvious head trauma, chest or abdominal or pelvis trauma, particularly if they're pale or sweaty and have any altered mental status. If you see them in a tripod position, leaning forward on their hands or their elbows in an attempt to breathe easier, or Levine's sign, that's the sign that a person makes as they clutch their chest over their heart when they're having chest pain that typically is related to heart attack. You want to get a chief complaint. And chief complaint is in the patient's own words why EMS was called. Now, it may be specific or like my abdomen hurts, or it may be extremely vague like I'm not feeling good or I'm weak or I'm dizzy. In any event, when we get those chief complaints, we have to develop a list of possibilities that could cause that chief of complaint and then start assessing our patient to see which one of those causes it is. Now, the patient's description of why EMS was called, remember too that at sometimes the patient isn't the one who called EMS. Somebody else may have witnessed something or seen something and quickly called EMS, which got you there. But just because you show up doesn't mean the patient called you or even wants your assistance. So forming an impression of the patient, we're going to look, listen, smell, feel. So look at the patient. How old are they? What sex are they? What position are they found in? Listen for obvious noises like moaning, snoring, gurgling, stridor, wheezing, things that would indicate that they're having trouble breathing. You can smell hazardous fumes, certainly if the patient reeks of urine or feces or vomit, or even decay as in the case of decubitus ulcers. When assessing the mental status, we're going to use a simple but efficient method to determine their level of consciousness called AVPU. When we use the AVPU, we start with the A. Is the patient alert? We all should know who we are. We all should know where we are. We all should know a general idea of time and usually what's going on or what happened. If a patient's eyes are open, they would be considered awake, but that does not mean they're alert. To determine whether they're alert, we need to ask them these silly questions like, do you know your name? Do you know where you are? Do you have a general idea of time and what happened? If they're not alert, do they respond to your verbal response? In other words, if they're lying there and their eyes are closed, and you tap and shout, or you say into one ear and then the other, are you okay? And if they don't open their eyes, then maybe they'll respond to pain. Now there's a variety of different ways to assess for pain. There's the noxious sternal rub, where you rub the sternum, but that's something that needs to be done for at least 30 seconds because it may take patients that long to respond. Another is to put some pressure on the eyebrow with your thumb. That's very painful. Another is to, squish a pen against their nail bed. That's painful. But perhaps the most effective way to assess pain is to squeeze their trapezius muscle in their shoulder. By squeezing the trapezius muscle in their shoulder, kind of like the Spock pinch, like Dr. Spock used to do on um, Star Trek. Uh, you'll elicit a response, and depending upon the response you get will also help you later determine your motor response in your Glasgow Coma scale. If they don't respond to a painful pinch in the neck, then they're considered unresponsive. The order of the primary assessment will vary, as we've mentioned, depending upon the patient's condition, but usually follows the ABC format. You want to identify and correct life threats before moving on. You want to gather information that will help you later in your assessment as well. Look for signs of life initially, including movement. Scan the chest for signs of breathing. If there are no signs of life, such as breathing or only gasping, check for a pulse. And if there is no pulse, then begin CPR and apply an AED as soon as available. If the patient is alert and talking clearly or crying loudly when you get there, you know that their airway is open. If their airway is not open or is endangered, you have to open it, and we'll talk about, well, we've mentioned methods on how to do that with a head tilt chin lift or a jaw thrust if you suspect trauma. Next, assess their breathing. If their airway is open, just because they're talking to you doesn't mean that their breathing is adequate. If a person's talking in one or two word sentences, that would indicate that they're extremely short of breath. You also want to listen to their lungs at this point, because listening to their lungs would give you an idea if they're having any trouble breathing, as in the case of prolonged expiratory wheezes that might indicate bronchoconstriction or asthma, or inspiratory stridor, which might indicate an obstruction of the upper airway. So situations that call for breathing assistance, in other words, you have to provide bag mask ventilations and assist breathing in the patient who isn't breathing adequately, would be that patient in respiratory arrest with a pulse. You're going to have to assist ventilations there. If the patient isn't alert and their breathing is inadequate, less than 10 or greater than 24, some would say greater than 28, you might have to assist their ventilations as well. Even if they have some alertness but their breathing is not adequate, we need to assist their ventilations. If the patient is exhibiting signs of respiratory distress or severe hypoxia, pulse oximetry is less than 94%, cyanosis, working hard to breathe, 2 and 3 word sentences, nasal flaring, intercostal retractions, all those sort of things, you may have to assist their ventilations. Now, assisting ventilations is not an easy thing to do, particularly in somebody who's short of breath. You'll have to put a mask over their face, and most often they feel like you're suffocating them. So you might have to sell that mask to them. You might have to convince them to allow you to give them a breath or two and then take the mask away, and then maybe give them 2 or 3 breaths and then take the mask away. But your assistants, you want to squeeze the bag as they're inhaling so that you're not fighting them. In circulation, we want to assess the skin. It should be pink, warm, and dry. Skin that is pale, cool, and clammy is a type of shock, but you can have warm, flushed, moist skin with certain types of shock as well, like sepsis or distributive shock, as in the case of neurogenic shock. You want to assess for a pulse in an unresponsive patient. And in unresponsive patients, it's best to assess for a pulse in the neck. And if you do not feel a pulse in about 10 seconds, then begin chest compressions. Pulses will either be within the normal limits, or they'll be unusually slow, which we call bradycardia, or they will be unusually fast, which we call tachycardia. You also want to assess and check and control severe bleeding at this time as well. Once you've been through your ABCs and you've fixed any life threats, you want to determine the priority of your patient. If they're a high priority patient, you need to move quickly to get them to the hospital. But if the patient is stable, then you have signs then you have time to do a more thorough assessment on scene before moving the patient. You want to make sure and treat any immediate threats to airway, breathing, or circulation in order before moving them. And patients who do have problems with their airway, breathing, or circulation are not stable. If no pulse, begin CPR while you apply a defibrillator. And there's times when you got a patient where you're not sure whether the patient is a high priority or not. If you're debating on it, then treat them as if they are a high priority. And remember that the patient's priority can change. Patients are dynamic. They change as time goes on based on the treatment that you provide, based on the severity of their illness or injury. In patients who are high priority, you want to transport them without spending a lot of excessive time on the scene. You can continue your assessment and care en route. So the primary assessment is a systematic approach to quickly finding and treating immediate threats to life. And those immediate threats that we're looking for have to do with perhaps an obstructed airway, perhaps with inadequate breathing, or perhaps with significant hemorrhage or no pulse at all. You can quickly determine a general impression which is subjective. In other words, you've not done an assessment, so you don't know everything that's going on. But if the patient is really sick, you can see that in a person who's really sick. You want to check their mental status using the AVPU approach. It's quick, it's simple, and we can determine their initial level of consciousness and then evaluate their airway, their breathing, and their circulation quickly, looking for immediate life threats. And then as you find a life threat, treat it before moving on to any further assessment. Remember, too, that your approach to the patient will vary depending upon how they present. The Heart Association recommends the CAB approach, where we start with chest compressions and then go to airway and breathing. Other organizations would advocate a CAB approach in a patient who has significant life-threatening hemorrhage, where we control the hemorrhage first and then go back to the airway and breathing. But in other situations, we're safe in using an ABC approach to do our primary assessment. If your patient shows signs of life and is breathing, then you'll take the traditional ABC approach. Remember, the mnemonic ABC is a guide to the interventions that may be taken. You'll choose your intervention based on the patient's needs. Do they need their airway open? If they're unresponsive and you open their airway, are they able to maintain it? And if not, you might have to use an oropharyngeal or a nasopharyngeal airway. Are they breathing, and is the breathing an adequate rate and depth? And if it isn't, you may have to assist their ventilations. Do they have a pulse? If not, CPR. If they do have a pulse, look for significant bleeding, and if there is significant bleeding, you'll need to stop or control that hemorrhage. The patient's priority describes how urgent the patient's need to be transported is and how to conduct the rest of your assessment. If they're a high priority, they need to be transported quickly. If they're a low priority, you can conduct the rest of your assessment on scene. Now remember to determine if a patient is responsive or unresponsive, and whether the patient is an adult, child, or infant, because how we treat adults and children and infants, particularly related to chest compressions and defibrillation and ventilatory rates and depths, vary depending upon whether it is an adult, child, or infant. Rapidly identify the need for immediate airway intervention, and airway intervention is opening the airway and then using a nasopharyngeal or an oropharyngeal airway or a king airway to keep their airway open. And then determine if the patient's condition is stable enough to allow further assessment and treatment on scene. All right, so that was a quick review of your primary assessment. If you have any questions, you know how to get a hold of me.